There is no doubt that IC pain can be very severe, if not agonizing. The very first research study that focused on pain found that IC pain was equivalent to terminal cancer pain. It's relentless, difficult to ignore, agonizing. And I was one of those patients. I have to be really honest. My first year with IC was absolutely agonizing. I had days where I couldn't sit, where I couldn't stand, where I couldn't lay down. All I could do was pace and cry. And yet, throughout all of that year, it never dawned on me, the pharmacologist, that a pain medicine would help. I foolishly made a decision. I was just in such distress that I thought maybe I just need to get away. And so my mother and I took a train up to Lake Tahoe, never thinking that a bouncing train ride would not be the best thing for somebody who's already in severe pelvic pain. And when we got to Tahoe, literally that night at 3 a.m, I had to go to the emergency room. It was so bad. And what happened at that emergency room is I actually got a pain shot. And it turned the pain off. And I went, what? Whoa, what? You can turn this off? I had just been suffering for a year and you just turned it off. Mind blown. And of course the pain medicine wore off and it came back. My sweet little mother, who at that point in time was quite elderly and had already decided she was never going to drive a freeway again, had to drive me home from Lake Tahoe, a 4-hour drive with me crying in the back seat as we would pull over and I would pee in snowbanks because I had extreme frequency. She was a lovely, lovely woman. And when we got home, I had to go back to the emergency room 2 days in a row in the middle of the night. My urologist finally took notice and went, oh, it's gotten really bad, hasn't it? And I was like, yeah, it has. And you have to understand that pain takes a terrible toll mentally as well. When you're in pain, you get into fight or flight. The anxiety builds. What's wrong with me? I personally thought that I was dying. I truly believed at the age of 32, I was dying. That surely this is the pain somebody must feel when they are at the end of their life, which it turned out the research study actually found that. But when my doctor really saw my physical and emotional state, my doctor went, oh, maybe we need to give you some pain medicine. And I was kind of like, yes, please. I truly believe that having something that could ease that suffering is one reason why I'm still here today. Because it was rough. Our challenge now, of course, is we have the opiate crisis. And the opiate crisis is not our fault. You know, an addict takes pain medication to escape life, to escape their responsibilities. A responsible patient takes pain medication to function, to do the things that we need to do to support our families so that we can cook, so that we can go to work, so that we can help our family, all that sort of thing. And so the use of pain medication is a valid and valuable resource for IC patients who are in severe pain, such as the patient that I was working with yesterday. And if you look at our national guidelines are crystal clear. Our national guidelines understand and respect the fact that IC can be agonizingly painful. And it is incredibly compassionate about pain care. They want pain assessed at every appointment. They want pain treated aggressively. They want multimodal therapy. What does that mean? That means we're not just going to throw pain meds at you, because pain meds just cover up the problem. They don't fix the underlying problem. It means that we have a depth of things that we can do to bring the pain down at its source and to help ease your suffering. Multimodal therapy. Now that we are doing phenotyping, now that we understand the distinct patient groups, now that we know the number one cause of severe pain in the IC patient is actually untreated Hunner's lesions, and now that we know that when we treat the lesion, the pain usually gets much, much better, to the point that they might not even have pain so much anymore, or certainly need pain care. And in my case, my pain was coming from incredibly tight, agonizing pelvic floor muscles. And now that we have and understand the importance of pelvic floor physical therapy and reducing that pain, this is why multimodal therapy makes sense. So what can we do for that pain? Number one, you got a phenotype. We got to figure out what your freaking phenotype is. We have to understand underlying causation. So if you've got a Hunner's lesion, man, that's why you're suffering. That's big time pain. We want to make sure that Hunner's lesion is treated. And we can cauterize that lesion. They can inject steroid in that lesion. But remember, we now have this new supplement, lactoferrin, which a year ago was found to heal Hunner's lesions in the majority of patients. Simple over-the-counter supplement. Lactoferrin. It is a protein found in colostrum that boosts the immune system. For patients who are bladder wall driven, we have to try to understand why the bladder wall is getting so freaking provoked. If you are using ketamine acts as a caustic agent on the bladder. That's going to hurt like heck. You need to stop the ketamine. If you're drinking a lot of diet soda, if you're drinking a lot of coffee, that is irritating to the bladder wall. If we want the bladder wall to calm down and that pain to go away, then we need to lose the irritants. Back in my first year, I was drinking a quart of cranberry juice a day, having no idea that cranberry juice was making my pain all the worse. And it took months and months for my bladder to heal from that dang cranberry juice that I was doing. So when we're thinking about pain in the bladder wall patient, it's not just treating that pain, it's understanding why the nerves in your bladder wall are so provoked in the first place. They're going to be provoked usually through chemicals. They might be more vulnerable because you are in estrogen atrophy, so we got to get the skin healthy. Might be provoked because you've got a chronic infection. That's possible. It's rare, but it's possible. But what we're finding is fungal infection. So if you flare when you eat sugar, then we got to look at that, because sugar makes candida, makes fungus grow. That's a sign that you could have a fungal infection. If you are pelvic floor driven, then the single most important way for you to reduce pain is by getting those muscles to relax and release. And we do that with physical therapy, and you learning how to do that on your own, perhaps using a wand. That's what I do. When I feel my muscles starting to lock down, my first symptom is I cannot pee easily. My second symptom is rectal pain. My third symptom is a pulling or pushing sensation. That tells me that my muscles are not happy with me and I've got to work on them. And if you are a widespread pain patient, if you've got IC and you've got IBS and vulvodynia or TMJ or migraines or fibro, or you have very sensitive skin or a wicked sense of smell, we know that it is your central nervous system that is driving and perpetuating the pain. And so therapeutically for you, we're going to do things that are going to calm nerves down, like PEA, like gabapentin. But even more important than that is we have got to get your central nervous system out of fight or flight. You have a dysregulated nervous system. This usually happens after injury or trauma. And so the patient that I was working with was hysterical, sobbing, and her anxiety was completely off the charts. She was so scared. And what is my rule? If you're scared, if you're at the point that you just do not understand what's happening to your body, that's when you go to the emergency room, in my opinion. That's what I do. And I don't want guessing, I want facts. The reason why I would go to the ER and why I did go to the ER was because I needed to know that I was safe. I needed to know that I was okay. I needed to know that I was not dying. Because that's what pain felt like to me. Our AUA guidelines encourage the use of pain medicine. They encourage over-the-counter analgesics like Tylenol, Advil. They encourage bladder pain relief tablets, pyridium to numb the bladder wall. They encourage bladder installations that will numb your bladder and calm the nerves down. And they encourage, if necessary, the use of opiate medication to get you through that crisis. The challenge is if you ask for pain medicine, they're going to say no. And flat out, many doctors just say, I don't do pain meds. This is my workaround. This is how I encourage patients to navigate this very, very delicate discussion. And that is, you have to talk about how you cannot function. So, doctor, I can't sleep at all. I am urinating every 30 minutes, every 45 minutes. I have not slept more than an hour in years. I am so sleep deprived that I do not feel like I should be driving, or I am having struggle concentrating at work. Or, doctor, I can't get up and clean my house. I can't cook food. I mean, I have worked with patients with pain so severe that literally they can't even get in the damn shower. So they haven't been able to bathe in sometimes weeks. When you talk to your doctor about how pain limits your ability to function, they get a better view of how it is affecting you. And the other thing you've got to remember is that doctors diagnose based on observation. They're looking at you, they're studying your body. And they're also, in many ways, incorporating their own life experience. God forbid you go to a doctor who has never in their life had any bladder symptoms and bladder issues at all. They don't get it. When you talk about how this limits your ability to function, you are giving the doctor a much better idea of the intensity of your pain and the limitation of your pain. Doctor, I can't go to church. I can't sit in the church pew. If I go to church, I have to stand, and I only last 15 minutes, and I have to go. Or, doctor, I would love to go to church, but I can't even sit in my car right now. And then the question that you ask your doctor is, what can we do to improve my ability to function? because I need to work, or I need to be able to care for my children, or I need to, fulfill my responsibilities in my community. What can we do to improve my ability to function? And when you craft it that way, you let the doctor bring it up. And the doctor goes, maybe we can try a pain intervention. And of course, there are several different types of pain interventions. The other great challenge that we have is that there are some patients out there who say, I don't want to be an addict. I'm not taking anything. And you got to understand that fighting pain is like fighting a fire. Man, if you had a little fire in your trash can, you would get a glass of water and you pour it on it and done, over. But if you let that fire build and build and build, and now your drapes are involved, and now the wall is burning, it's going to take a lot more water to turn that fire down. And that same is true with an IC flare, and that same thing is true with pain. We have to catch it early. You don't push until you're sobbing, and then at that point in time you go, okay, maybe I'll use a little bit of the pain medicine my doctor has given me. You've just now your pain is so severe that small little medication they gave you is not probably going to do anything. And then you're taking more. And then you really do look like a drug seeker. It's about recognizing pain, recognizing that flare as early as you can, and nipping that in the bud. And that is why, all right, where is it? Where did I put it? Here it is. Okay, and that is why we have our guide to managing flares. It has interventions that you can do in the very first hour that can prevent this flare from cascading and growing to the point that it is now out of control and you need extra help. And so, let's see here. So for a bladder wall flare, for example, we know what the triggers are for bladder wall pain. It's chemical exposure. It's going to be diet. It's going to be things like vitamin C and harsh aggressive supplements like cranberry. We know hormones are going to potentially affect your symptoms. Very normal for somebody who has not gone through menopause yet to flare the day they ovulate, a couple of days before their period. That is a flare that you do not have to worry about. It's just a very, very short-term flare that happens when estrogen levels peak or drop, depending upon how you respond to estrogen. And we certainly know that chemical exposure. So what are we going to do for this flare? So the first thing you're going to do is just sit down for 30 minutes, please. We got to calm your entire body down. We just got to calm everything down. We're going to dilute your urine. If your flare was caused because you drank coffee, okay, first thing we're going to do is dilute that urine to reduce the acid in your urine that's irritating your bladder. We can alkalinize your urine to, again, further reduce some of that acidic irritation. We can do something as simple as an herbal tea, chamomile tea, peppermint herbal tea. They're both smooth muscle antispasmodics that can calm that bladder and preventing it from getting this, where it really starts to spasm and bother you. You can use heat to relax muscles. You can use cold therapy. So we have first hour interventions. We have second hour interventions. And then getting more serious about pain. If, for example, you have a bladder wall flare and no matter what you do, it's just not helping, that's when we go back to the doctor and we can ask for a rescue install. A rescue installation coats the bladder and numbs the nerves. It's called a rescue because it rescues you out of a flare that you would normally walk out of that doctor's office pain-free for several hours, maybe even a couple of days. always remember that pain medication covers up symptoms. It doesn't fix anything. We have to get to the anatomy. We have to understand what in your body is driving these symptoms in the first place. And if you haven't had anybody look in your bladder, for God's sake, let them look in your bladder. Because maybe it's something simple like bladder stones in your bladder. Or, you know, if I'm in pain, I don't want anybody to guess. I want them to look and tell me why I'm in pain. And if there was ever a reason to allow somebody to look in your bladder, it is if you have been in pain for a significant period of time and that pain is getting worse. Guessing will never get you or your doctor where you need to be. We need facts. And the fact is, what is going on with your bladder? Now, if they look at your bladder and they find Hunner's lesions, okay, mystery solved. Now we know why you're in such pain. Now we're going to treat the lesions. Hopefully the pain will go away. It usually does. If they find nothing in the bladder, great. That means that we're dealing with a healthy bladder. That tells us that something outside of the bladder is the problem. Could you have very tight pelvic floor muscles? Could you have pudendal neuralgia? Could you have a fibroid tumor pushing on your bladder? Could you have endometriosis attached to your bladder? The whole point here is that we're not going to give up and take pain meds for the rest of our life. For God's sake, no. You got a life to live. So I hope this makes sense. Pain is a message. Your body is in distress. We have to figure out what is happening to keep it in distress. In some cases, it is easily identifiable, like a Hunner's lesion, like a UTI, like super tight pelvic floor muscles. And in other cases, the pain is not as easily identifiable. That's that widespread pain group. That widespread pain group, that's where we're dealing with a central nervous system that is dysregulated, a central nervous system that is amplifying pain throughout the body. So for these patients, yes, you're going to want pain meds, but pain meds are absolutely not going to fix this, because underneath it all, what we're dealing with is a brain that's in fight or flight. And that's usually trauma-based. And for those patients, we have got to get that central nervous system back out of fight or flight. We've got to calm that central nervous system down. And when we do that, the pain, just goes down everywhere. Everywhere. And those are the patients who are like, don't tell me it's all in my head, but nobody's saying it's all in your head. This is about an injury. It's an injury to the central nervous system, and re-regulating that brain and working with good mindfulness methods to bring it out of fight or flight is critical to reducing pain levels throughout the body. That is why every pain management program out there usually has mindfulness, because we know that anxiety amplifies pain. When we get you out of anxiety, it brings all the pain down. So anyway, I'm kind of rambling here. And for those of you who joined from YouTube, the YouTube stream, my YouTube computer died last week. It died like 5 days ago. And it doesn't have USB ports. It's a more current computer. And I don't have an easy mic that will plug in. So I was kind of adapting and it didn't work. I'll have to go down to Best Buy and buy a new microphone. So I'm going to have 2 microphones here. All right, let's go to your questions. I apologize for talking as long as I did, but you know what? That's what I'm here for. Lisa, okay, so, hi Maureen. Lisa said, another gnarly UTI and my white blood cell count was pretty high. So that's why you're back in the hospital. Girl, have they identified it? Aaron says, my first year was horrible too. I had to take leave from work. Felt like I was having a nervous breakdown. Yeah, I finally, after my 3 days in the at the ER, and then I got referred to UC San Francisco because the local doctor just didn't know what to do with me. I went out on disability leave too. I was out on disability leave for 6 weeks. while I was trying to get into this IC research program, and I had to have all this testing, and we were getting ready to do surgery. Listen, I thought I was dying of cancer, so much so that I demanded exploratory surgery. I just told my doctor flat out, when they diagnosed me with IC, I said, I don't believe you. I think I'm dying of cancer. I want a laparoscopy. I want you to open me up. And my doctor was like, really? And I was like, oh, hell yeah. Absolutely. I want to figure this out. And I remember I had it on like September 21st. And I woke up in the recovery room and they said, Jill, you're perfectly fine. We found nothing. You had a perfectly healthy bladder. What I had was a very, very, very tight pelvic floor muscles. Katie said, I had my cystoscopy fulguration 3 days ago. It went well, but today you're peeing every 20 to 30 minutes and last night every hour. Okay, so Katty, here's the deal. You had a medical procedure 3 days ago. It is very common to have what we call a nosocomial infection after a procedure. That means that during that procedure, they accidentally introduced bacteria into your bladder, thereby triggering an infection. And generally that infection begins about 48 hours after the procedure. So the fact that your symptoms have now come back and they're getting more severe, you need to call your doctor and you need to go get your urine tested. Let the doctor know that you suddenly got worse. They need to work you up for a post-op infection. Okay, that's very, very possible. Taryn said, I'm just like you, tight floor, found you in 2018. You got me on track with diet alone. Yes, I'm that old. Debbie says she's pelvic floor. Yep, confused. So you think it's pelvic floor, however, so much pain. Recently took a bad fall and got a hip injury. Could not pee for 10 hours. Not note such pain in the bladder. Okay. So this is classic, Debbie. Classic. Here you have, let's just say, pre-existing pelvic floor tension. Pretty controlled. But then you had a trauma. You had a fall. That fall was so severe, your muscles got really, really tight. And guess what? When the muscles get really tight, bam, it makes it very, very difficult for you to urinate. Can't pee afterwards. That's when immediately, like one of the rules is if you cannot pee, you have to go to the emergency room. That is considered a medical emergency. Terrence says, my urologist said patients come to him suicidal from the pain. That's very true. I was. I can tell you the date, July 4th, 1993. I was past hysterical. I was just disassociated at that point in time. I was in my bedroom walking in circles because I couldn't sit without pain. I couldn't lay without pain. I just paced, crying. And, thank God that I had family who took care of me. Family who took me to the emergency room. I had compassionate doctors who saw it makes no sense for a 32-year-old woman to be in the emotional state that she is if she were not in severe pain. And I think once I begged for a bedside porta potty and they saw me sitting on it all the time, they really realized that yes, Jill Osborne did indeed have a severe bladder problem. I needed some pain care. Aaron says, where can you get a copy of the IC Optimist? In the IC Network shop, honey. Taryn says, heard it's autoimmune related. Yeah, it can be for some patients, not all patients. I know that there's some doctors out there telling everybody it's autoimmune. That's not true. Again, we have phenotyping, but there's a small percentage of patients where it is autoimmune related. Lisa said, thank you for being here for each of us. You're welcome, honey. Thank you for the 100 stars. Really appreciate that. Joanne says, regarding phenotypes, I have Hunner's lesions, so that's the source of my pain. Can you have more than one type of phenotype going on? My nervous system is totally whacked. Anxiety, panic attacks, sleep deprived due to constant urination all day. I have such urgency that I'm incontinent and go through eight or nine pads a day, but the incontinence is not part of the IC diagnosis. My urologist says he doesn't understand why I cannot hold my urine. Here I am. So I have a couple of different ways that we can talk about that. Ultimately, it's the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for every IC patient out there, that's the question we try to solve, because that tells us the direction a treatment needs to go. So if your IC began during chemotherapy, then we know that the chemicals of the chemo damage your bladder. And that bladder is screaming in pain because it's getting provoked badly. And when you're in pain, your muscles get tight in a guarding response. So for that patient, our therapeutic priority is going to be first calming the bladder and reducing the source of irritation. And for anybody out there that this has happened to, there's a medication called Mesna or Mesnex that can reduce, it can completely eliminate the chemo-induced bladder sensitivity. Okay. If, on the other hand, and this is really, really common in my office. I mean, I love talking with you guys because we do a deep dive. So if a patient calls me, I want to know, how old are you? How old were you when your symptoms began? And was there any event that you associate with the onset of your symptoms? So for some people it's traveling, for other people it's a fall, etc. But if we go back in time, 85% of IC patients have tight pelvic floor muscles. Research has proven that, 85%. And for those patients, if we go back even farther, we can see how that pelvic floor tension began. So I was working with a patient like on Friday or Thursday, who was a gymnast and a dancer. But all you got to do is say gymnastics is like, all right, okay, we know exactly where it began. That constant falling on your tailbone, the constant falling and pressure and stress on the pelvic floor from gymnastics creates the perfect foundation for slow but steady tension to build. And then eventually the muscles get so tight, she's in a state of ischemia. Now it's affecting the bladder and the health of the bladder. The bladder is not getting the blood supply it needs to be healthy, and the bladder wall starts to break down. Now for the patient, she has no idea she's got all this muscle stuff going on. No clue. Her first symptom is frequency urgency pain. She's going, Doc, I got a UTI. Doctor gives her antibiotics. They don't work. She goes back. The doctor says, let's do long-term antibiotic. They don't work. 3-6 months later, they don't work. She goes back to the doctor. Doctor goes, let's do some overactive bladder stuff. So they give her a diterpanodetrol. That doesn't work. And eventually, a year or two later, the doctor goes, God, I hate to break it to you. I think you've got this incurable bladder disease called interstitial cystitis. Here is the diet. Here's the medication. I'll see you in 6 months. And that patient legitimately wants to get better. And so they're like, oh, thank God I've got a diagnosis. I know what to do. It's real. I don't have to be embarrassed anymore. That patient follows the diet and they do the bladder medications for 6 months, a year, 2 years, 5 years, 10 years, 20 years. But they still flare. They're still peeing all the time, even with all these bladder medications on board. If they've taken Elmeron, the odds are they might start having eye issues and bowel issues. The challenge here is that no bladder therapy is going to fix tight pelvic floor muscles. No bladder therapy is going to fix ischemia, which is the underlying problem for the bladder wall sensitivity in the first place. Our therapeutic priority for these patients is to restore blood supply. That when we get the blood supply flowing again, the bladder finally gets nourished again. It gets the oxygen it needs. It gets the nutrition it needs. The bladder wall heals. And the symptoms improve. And that also is proven in research. In our major physical therapy studies, 70% of patients who did physical therapy got massively better. Whereas you look at the research for bladder treatment, all of them very, very poor, rarely successful. So, Joanne, your chicken and the egg is interesting. So you have Hunner's lesions. So the Hunner's lesions could be caused by a viral infection, or the Hunner's lesion could be caused by a broken ligament, the uterosacral ligament. If you have a history of prolapse, if you have a history of incontinence, muscles getting very weak, things moving out of position, unfortunately, the uterosacral ligament is a pathway and a structural support for nerves coming out of the bladder. It's called the visceral plexus. And when this ligament is broken, these nerves dangle. And they get stressed. And they get inflamed. And that inflammation can cause a lesion. So, if I were in your shoes, I would, given the fact that you have Hunner's lesions, I would, and given the fact that you have incontinence, I would want to be screened for posterior fornix syndrome, and let's just make sure you don't have a broken ligament. Because we have a case study of a woman who was completely cured of her Hunner's lesions when they restored the visceral plexus by repairing the ligament, and I can give you that research. I might also want to be have you screened for a viral infection. If you have a history of exposure to mononucleosis, we now know that mono Epstein-Barr is often found in the urine of patients with Hunner's lesion. And if that's the case, then that opens up the door maybe to using some antivirals, and it certainly opens up the door to lactoferrin. Lactoferrin, it's kind of like, what do you have to lose? It's an over-the-counter supplement, remarkably safe. The IC study was stunningly successful. And if there's a chance that it can take what that IC study found, that in 28 out of 31 patients, they had no symptoms afterwards, and red inflamed bladders became pink and healthy, and Hunner's lesions almost completely disappeared. So that would be something else that you can do for the Hunner's lesion. If you have tight pelvic floor muscles, if you've had Hunner's lesions for a long time, you've been in pain for a long time, then getting that physical therapy in to get those muscles to relax and release will only help. It will not hurt. It will help. And the legacy of all of this for you is that you are in central nervous system dysregulation. You're struggling with anxiety and panic. Now, for some patients, that happened before everything else. That these are patients who have a long history of anxiety and panic because of adverse childhood trauma. And that creates a foundation for a lot of stuff happening when you're an adult. Well, it is what it is. You've got anxiety, so we got to work on the anxiety. And in our flare management guide, I have a whole section on stress flares. Listen, we've all had stress flares. There's no person out there. I see a patient who is not flared with stress. So what are the triggers for a stress flare? Well, stress. From a stressful workplace to conflict at home, stress can lead to persistent fight or flight, which can trigger a variety of symptoms in the bladder, bowel, migraines. I mean, honestly, if you tell me I got to get on a plane tomorrow, I can promise you I will be up tonight with IBS and IC. Happens every single time because I don't like to fly. I had a near miss in a jet. We were landing at Santa Barbara. I was flying back to school, to college. I went to UC Santa Barbara, and we were like landing. We were almost touched down when a plane taxied on the runway, and the jet that I was on went like this and went like this. And in a second, I was looking down at my dorm, and our plane was like this. Scared the living daylights out of me. And yeah, it leveled out, and we turned around, and the pilot apologized and said, "We're sorry. Somebody taxied on the runway. We would have hit them. We had to go around, but we didn't mean for it to be so extreme." Anyway, adverse childhood events. But also, the other thing that's going to trigger the central nervous system is caffeine. Caffeine. Anything that's neurostimulatory. Man, it's like taking a jackhammer to your nerves. Chemical exposures. Or something as simple as having to get on a plane and not being allowed to use the restroom. That stress triggers flares. I went to my second year, and again, my IC was really bad. Somebody bought tickets to go see the actor Patrick Stewart doing a one-man Christmas show. He was bringing it to Broadway, but he was testing it at local places, so he came here, and I'm like, oh, I'd love to see him. I love Star Trek. I love Patrick Stewart. What I didn't know is that my friend got tickets directly in front of the stage, like 3 rows back, and in the middle of the section, so I couldn't get out easily. Oh my God, I had the worst flare ever. Oh, I was just dying. Okay, so in our guide, what do we talk about? We talk about after the flare begins, for that stress flare. Number 1, deep breathing. If you use the 4-7-8 breathing technique, which is breathe in for 4, hold for 7, go breathe out for 8. That activates the parasympathetic nervous system, and it takes the brain out of fight or flight. Deep breathing. Getting a walk. Take a quick walk. A slow, meandering walk, because that reduces stress, improves circulation, and start to produce your natural painkillers, your endorphins. You can try reflexercise. So when standing, curl your toes into the ground as if you're gripping the surface. You're not running away, you are anchored to the ground. Then open your arms to the side, palms facing forward. Your hands are not clenched, they're relaxed and open. The front of your body is open and receptive. You're not hunched, you're not hidden. Turn your head from side to side. Close your eyes. Put your tongue between your teeth, and then take some breaths. I've been doing a lot of deep breathing the last couple of years. Or you can try the power pose. Remind your body what it feels like to be in control. Amy Cuddy gave a fabulous TED Talk about how body posture influences your attitude, your brain, and your nervous system. So stand tall, legs spread, chin out, arms up. The Wonder Woman pose. I am ready to take on the world, baby. I am ready. Hold that position for 2 minutes. This increases testosterone production in your body, increases courage in your body, but at the same time, it decreases cortisol. It decreases the stress hormone, and it can help reverse adrenal fatigue. Man, so if you're ever in a situation where you don't feel powerful, like when you're walking into the doctor, do this first. Take your power back. Body position influences your nerves. You can do inversion. Lay on the floor, put your legs up on a couch or wall. This creates nice blood flow to the brain and the lymphatic system, which can improve anxiety and depression if you do it for 15 minutes a day. But you got to be careful. If you have blood pressure issues, probably need to talk to your doctor about that first. And then we go through some techniques that can physically turn your brain fight or flight off. I do the I Spy technique, which I've done many times in these meetings. One of the things I really like is bumblebee breathing. Bumblebee breathing is you inhale completely and then you exhale and put your lips together and hum. So you go in and then it works. Or you can do tapping. It's a form of psychological acupressure that turns off the amygdala and the stress response. It uses finger tapping at meridian points to balance energy by sending signals to the brain that controls stress. So it can and should be used if you're struggling with intense anxiety. Anyway, and then, so we all have to take responsibility for learning better how to manage stress and anxiety, because right now our world is messed up. Everybody's stressed financially. A lot of people are stressed out by politics and all this sort of stuff. I can't think of a time in my lifetime, 65 years, other than, well, I wasn't alive during World War II. I was alive during Vietnam and the Gulf War. We're almost in a state of war with the level of stress we're feeling. And so we all have to take responsibility for learning how to manage that stress more effectively. And then, of course, we can do PEA, the PEA supplements like Peora, P-Leaf are outstanding for calming nerves down. Those are in the IC Network shop. You can do a low-dose antidepressant, although those come with a lot of side effects. Or even gabapentin. Anyway, we have lots of tips in this flare management guide for lots of different types of flares. So last but not least for Joanne, my urologist says he doesn't understand why I cannot hold my urine, so here I am. Well, that's either related to very weak muscles or that's related to nerves. So I would want you to have a pelvic floor assessment and let's see what they find with your musculature to see if there are muscle issues going on, if you haven't done that yet. Karen says, sweet tea was the hardest to give up, but worth it in the end. I miss it so much better, but pain-free is much better. Yeah, absolutely. Lisa said, the hospitalist, so guys, Lisa's in the hospital right now. The hospitalist here doesn't believe in pain meds, but this UTI was killing me. She thought Tylenol was enough. Finally, she did some research and found pain meds are appropriate. So you alternate between Dilaudid and OxyContin. Good. Karen says, VA hospital won't give pain meds for anything. Well, so then if you're in a situation where you are being refused care, number one, I'm really sorry that you're in that situation, because I do completely understand that you're suffering. You can do it, you can approach it in different ways. Again, your number one question is, what's causing the pain in the first place? Where is this pain coming from? Is it coming from a Hunner's lesion on my bladder wall, or is it coming from tight pelvic floor muscles? Your question is always needs to be, I want to find the underlying problem so that I can fix the underlying problem so that I'm not dealing with the pain anyway. And when you make that point to your doctor, that takes you out of the, this person is just looking for pain meds, to, oh, this is a person who really wants to fix it. Because you got to understand that there are a lot of people out there who are gaming the system because they're selling drugs illegally, or they really genuinely do have a problem. And so the way you distinguish yourself from that group is by really saying, listen, I don't want to take pain meds. I want to find it and fix it. Can you help me find it and fix it? And sometimes a doctor is going to send you off to a pain clinic, and that's great, except that's the same attitude you need to take with them. It's like, would you please help me understand where this pain is coming from? And how do we turn it off at the source? Some pain clinics are designed to just get you off opiates, and they're kind of like a drug treatment center. Others are very diagnostic. They will do pain blocks. They will do lots of other things to help find that underlying problem and fix that underlying problem. Shelley says, any experience with platelet-rich plasma? Very, very little. We just, it's almost being kind of disregarded and thrown to the side like it's a fad. I'm not seeing a lot of the mainstream doctors doing PRP, which is sad. PRP, it looks like it's being done more by holistic clinics. Taryn says, my UA is always contaminated. I now wait 4 days before contacting my doctor to see if it's a flare. Okay. You thought you were dying too in the VA. Yeah, I understand. And listen, TRICARE sucks. We all know TRICARE sucks. TRICARE is a health insurance for the military. Lisa says, I'm not an addict, but I'm end-stage bladder and this UTI is killing you. Yeah. So you've got pain care. Thank God you got some pain care. But that doesn't mean you can't supplement that pain care with maybe something like PEA, because PEA actually helps opiates work better. So you might not need as many opiates. So again, multimodal therapy. This is not just about pain meds. This is about looking for other things that can help relax and reduce that pain. So anything from deep breathing and working on that anxiety, which I know you're in because you're in the hospital, to pain medicine, to physical therapy. Those are all viable approaches to try to reduce your pain. Erin says, what's my recommendation for vaginal dryness? I'm 66. I do use estradiol cream 3 times a week, but you need something in between. Well, Erin, if your pain is on the outside, then, oh, that's easy. This is becoming my favorite product that we have in the IC Network shop, and I use it regularly myself. Vulva Balm. It very closely mimics natural mucus, so you can see it's just a very, 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 very light oil that you put on the skin on the outside. You have to remember that your normal mucus is hydrophobic. It pushes water away. So using water in the end does not protect it. Water might cool off the skin and make you feel a little bit better, but it doesn't help restore the function you need, because mucus is naturally hydrophobic. Mucus is naturally a slight oil to push water away, to push urine away from the skin. And so using a slight oil to protect that skin is vital. Other people do Replens. You know, there are vaginal moisturizers that are on the market too. Replens is one. It's very tricky. It's very it's you always want a doctor to look at the quality and health of your skin, because if your skin is still profoundly atrophied, 3 times a week might not be enough. They might need you to do it 5 times a week. But that's your doctor's call. It's not my call. It's your doctor's call based upon what they observe on your skin. But you got to understand, estrogen atrophy. You know how painful dry mouth is. When you have a dry mouth, what do? You constantly drink water, because water eases that. Well, dry vulva, dry vagina is just as painful. Your mucous membrane tissues, which is your mouth, your vulva, your vagina, your urethra, and your bladder, have our mucous membrane protected. The skin relies on a nice thick coating of mucus to protect the cells and to protect the nerves and to protect the tissue. When you lose your estrogen, those tissues cannot make that mucus as much anymore. So that mucosal barrier gets thinner and thinner and thinner and drier and drier and drier. I've worked with some ladies who I'm not lying. Their little vulvas are like dry potato chips, and they are in agony. The skin is meant to be moist. It is meant to be protected. And that's why something like Vulva Balm can be pain reducing and kind of life-saving in a way. Taryn says it causes IBS issues. Yes, girl, it does. Why are you back on Elmeron? Why are you back on Elmeron? I mean, listen, the research behind Elmeron now is just heartbreaking. I have an article on our website called the Tarnished or the Tragic and Tarnished History of Elmeron, and how flawed its FDA approval was. That the FDA actually rejected it for 5 years, because the research. So to get FDA approval, you need to provide 2 research studies showing that it's working and that it's safe. Well, so the company that owned it gave them 2 studies. The first study was thrown out as being completely a complete failure. The second study they gave, which was of a couple of doctors who were using it, only one doctor showed success, the guy who invented it and the guy who owned the patent. All the other doctors who used it had no success with it. And so the FDA, basically said, listen, we need another research study, not with the patent holder, with somebody else. We need other doctors to do this, because with the data that you've given us, you're basically saying only one doctor in the United States is successful with Elmeron, and that is the guy who invented it. Everybody else who's tried it has not shown success. And so FDA said, give us another study. We want more research. And the company didn't want to pay for it. And so they said, no, we'll just reanalyze the data. And they submitted again. The FDA rejected it again, saying, listen, again, you need to give us more research showing that this is effective and safe. And the company balked, and then they said, well, we'll give you some compassionate use data. Now, compassionate use data, these are when a medication is made available for compassionate use, that does not mean that it's safe or effective. There is no research that's done that. Compassionate use is when you give a medication to somebody who's desperate where there's no other treatment. And so Elmeron was approved for compassionate use data, I think in 1986. Was it 86? I might be wrong on that date, but you can find it on our website in that article. And so the only people who were using it back then were patients who got it on compassionate use. And again, the FDA says this does not mean that it's safe or effective. We're just making it available because these patients have nothing else. And so they had years of compassionate use data and a patient stories. They submitted that to the FDA, and somehow the FDA forgot their request for additional research and approved it. And of course, the very next year, there were 400 adverse events filed with the FDA for problems with Elmeron, including they knew that eye issues were happening in the compassionate use data. That first year, there were many reports of I take back many. There were some reports of patients who were having bowel issues. The heartbreaker here is that Elmeron was in the wild for 18 years before they finally did the research study with multiple doctors to prove that it worked. It's called the Elmeron Working Group, and they published that research in 2015. And guess what? Didn't work. It didn't work. And the doctor who ran that study, Curtis Nichols, said, we thought it'd be pulled from the market literally very, very quickly because it was not found to be effective. 18 years it's out on the fly. 18 years. Patients were taking it. Some of those patients now have severe eye damage and inflammatory bowel disease. 18 years without that research study showing that it was safe and effective. And then when we finally get that research study, what happens? It's still on the market. Why? Why? Well, in Europe, for example, they based the approval in Europe on the research that the FDA threw out. Or they based it on research made by the company itself where there's a clear financial incentive. Or they found a reason to throw out the 2015 study. And the reason was they didn't do hydrodistensions on every patient, something like that. And it's like, well, that's because in the United States, we don't require hydrodistensions on every patient. Anyway, do not get me started on this. I have very strong thoughts on this. Thank you, Joanne. I'm glad you're going to order that book. Taryn says, I'm in pain management, working on finding long-term non-narcotic treatments. So look at PEA, honey. Here is it. Where is it? Peora or P-Leaf. These are the two PEA. This one's been out longer. This is very new, but pretty much the same thing. Many patients use this for flares now and use this for pain control now. And the research study done in 2019 showed that 87% of IC patients who used PEA had a significant progressive reduction in their pain over time. And I have that research on our website, right on the front page, if you want to look at it. Kayleen, yes, the YouTube, my computer that I normally did my YouTube stream on finally died. And so I'm trying to use a new computer, but it's not accepting the microphone. And so I couldn't get sound. So I have to go buy a new microphone. I see, that's why I have this here. This failed. This was the microphone I was trying to use on the new computer. Laura said, I was on Elmeron for 25 years. After hearing about the eye issues, I went off and there was no change in my bladder, so it wasn't even helping. You know, see, Laura, that is exactly the point here, because now that we're phenotyping, now that we know that 85% of IC patients are muscle-driven, there was no chance that Elmeron would have ever helped them, because their fundamental problem was not their bladder wall. Their fundamental problem was their pelvic floor. Taryn, if you can, go read that article on our website, The Tragic and Tarnished History of Elmeron. It is right on the front page. So you can look at that research yourself. You can make the decision yourself. But it's just, the word that comes to mind is disgusting. It's infuriating. It's infuriating when you go back in time and you look at these very clear steps that were not met. And the real question is, why would the FDA approve a medication without the research showing that it worked? And that goes back to the AIDS crisis, the HIV crisis. Back when HIV was rampant in the early 1980s, actually when I was in college, you know, tens of thousands of people were dying agonizing deaths, and both patients and doctors were begging for new treatments, and they petitioned the FDA to let medications through that might save lives without the research. And the FDA buckled under their will and said, okay, we're going to give you access to these meds, but we cannot guarantee that they're safe and effective. And the pharmaceutical companies liked that. They started taking advantage of that, because you know what that meant? They didn't have to spend money to do more research. It's like, okay, let's give them a basic study, and even if it's not very good, maybe they'll approve it anyway. And then some of the companies said, approve it, and then we'll do the research after we're approved, and then they don't do the follow-up research. Or the follow-up research shows it didn't work. There was this fantastic investigative report in the journal The Lever, which is linked to my article, that goes through, I think that right now that there are like 10,000 medications approved by the FDA with no research showing that they work. Most of them are for cancer. Taryn said, stop the Elmeron as of today. Elimination diet had worked for so long, I didn't need anything. Okay, so Taryn, again, the question is, why is your bladder wall vulnerable? So the fact that foods irritated you points to your bladder wall. So your age matters. Commonly what we see is just estrogen atrophy, that if you're on birth control, if you're on Lupron for endo, or you're just getting older, or you're on an estrogen suppression medication for breast cancer or any type of cancer, when those estrogen levels drop, the bladder wall gets thinner and it gets much, much more vulnerable. And it starts triggering flares. And again, it might feel like a UTI, but the cultures are negative. That's just a bladder wall that's dry and urine is irritating it. You know, guys, the bladder only has one way to communicate to your brain to tell you there's a problem. And that's because the bladder only has two functional nerve groups. It's got the alpha afferent nerve, which controls frequency, and it has the C fiber, which controls pain. So when the bladder is in distress, what does it do? It gives you the symptoms of frequency, urgency, pressure, pain. So anytime there's an issue going on with your bladder, those are your symptoms. And your first assumption is always going to be it must be a UTI. You've got to understand that injury causes exactly the same symptoms. Cancer causes exactly that same symptom. So frequency, urgency, pressure, pain is how the brain tells you that there's a problem. Sherry said, my pelvic female doctor told me you use coconut oil, and I used heparin and antibiotics in my bladder. I'm doing okay with it. I have breast cancer, so my female parts are very dry. Girl, me too. Which is why vulva balm to protect that dry skin is really, really helpful. Coconut oil is fine. The problem with coconut oil is it's messy and it soaks through everything. And so before we had vulva balm, I mean, I'm 65. I went into estrogen atrophy when I was like 52. And I used to use coconut oil until one day I was wearing a long navy sundress. And when I got home, there was an oil stain right where my tush was, and it looked like I'd leaked. I hadn't leaked. It was coconut oil that had soaked through my underwear. So vulva balm does not do that. Karen says, I have nothing for pain except azo. I know it's not good, but the pain is unreal. I take bladder rest and PEA and lactoferrin, hoping the azo for a bit of time won't cause cancer. You're also on hormone replacement therapy. Okay. Well, have your doctor look at the quality and health of your skin, and let's see where you are. Understand that for the bladder, taking oral estrogen is not going to be particularly helpful. It's putting the estrogen on the skin, which is the most helpful. And oral estrogen is associated with a greater risk of cancer, where topical estrogen is not. So, anyway. Karen said, my cousin has eyes too. She's been having eye issues. She's taken Elmeron. My grandmother had it. Genetic predisposition is probably my phenotype. We don't have, so we have to understand mechanisms here. So is there a genetic predisposition to have a damaged bladder wall? I don't think so. But what there is genetic predispositions but it's not even a genetic predisposition, it's more our biome. It could be, because remember, now we're really all making massive connections with the state of our biome and it causing lots and lots of different health problems. And so that gets passed down, because when a new baby is born, the mother's biome is what builds, and the mother's colostrum is what builds a baby's immune system. What the mother eats and how that food supports their biome directly affects mother's milk and the quality of milk and the child's biome. And you know, it's interesting, by the way, I love watching Netflix Korean dramas. And there is this sweet one that was called The Princess and Four, or The Cinderella and Four Princesses. If anybody ever wants to watch something that's absolutely delightful and sweet and encouraging, Cinderella and the Four Princes, I recommend highly. But, you know, in the process of watching all this Korean stuff, I have started watching other videos. And there's this guy who every day puts his Korean lunch on. And it's like at school where you've got, you know, you or a cafeteria where you've got a plate and it has all sorts of different sections in it. The Korean diet is so much healthier than our diet because at every meal they eat fermented foods and a prebiotic and a probiotic to nurture their biome. I should show the you know what? I could show the video. When you look at what the Korean lunch is compared to a hamburger and potato chips, which does nothing to support our biome, it's no wonder that we in the United States are struggling with so many chronic illnesses that they're now connecting to the state of our biome. I love watching that stuff, and I just like dawned on me, you know, they eat fermented foods every day. I might eat, my closest thing I get to fermented food is a yogurt. And it would scare me to eat kimchi or sauerkraut because I have gut issues. And why do I have gut issues? Because my biome is so bad because I didn't grow up eating that stuff. I'm trying to get there. Kayleen said, my AC urologist told me that hydrodistensions are useless in old school. I'm glad I haven't had any because the first one they didn't do anything. Well, it's diagnostic, really. Hydrodistensions now are used if the diagnosis is in doubt to let the doctor look at your bladder. It's not, it's an old school therapy. It doesn't do anything constructive for the bladder. It breaks the nerves, and that's why patients feel better. So it's why I call it a destructive therapy, but the nerves always grow back. And so relying on a hydrodistension for treatment is not going to get you anywhere in the long run. Taryn said, I'll consult my pain management pharmacist to ensure there's no chemical interaction with my current medication list. You have multiple autoimmune diseases. After receiving the anthrax vaccine, you take a lot of meds, unfortunately. And I was just reading an article yesterday on how the biome influences the thyroid and how biome dysfunctions are linked terribly with thyroid function. And I think about, okay, in my early 20s, I had severe IBS, and I was found to have low thyroid. I've been on thyroid medication since I was like 21 or 22. Hi, David. Nice to see you, hun. Taryn says, I'm a dissertation away from being a cognitive psychologist, and I'm ashamed I haven't done my own research. I know better, but it's why I'm trying to exhaust all avenues before resorting to pain meds. Girl, if you need to gather data for your dissertation, you want to do a survey or anything like that, call me. I've helped many patients get their dissertations or do their senior project. I'm happy to do that. I haven't done one since COVID. But I'd love to help you if you want to try to do an IC study in some way. Kayleen said, I'm finally getting back to myself after surgery. There's still a little pain, but I haven't seen any blood. Good. And no incontinence. Good. Excellent. I have a neighbor who's got stage 4 cancer, and so I told him, I said, listen, we cancer patients need to stick together, and so we play games now, board games. Last night we played Life, and then we played a ski game, which was hysterical. But I was saying to him, we were talking about this last night, that it's like finding yourself after trauma is really hard. And that's what I've been struggling the most, is finding myself after years of stress, caring for my elderly parents, having them dying, and then having cancer and having massive surgery. And, you know, you have to, and what's the rule? There's nobody's responsible but for your happiness but you. There's nobody that should be working on my self-esteem but me. And it's my job to do things that will bring me comfort and joy. I can't rely on anybody else to do that. It's my job. And finding that is hard. I know for me, I want to laugh. And I, as Kayleen knows, because I gamed with her for a year, I love playing games. But more important than the game is just the laughter. And finding people to relate to and joining clubs and a walking group or whatever. I'm back at the gym. That's like so good for me. In fact, I need to go after I'm done with this meeting. And says, vulva balm does not replace estrogen. No, it does not. Lori says, will fermented food irritate the bladder wall? Well, sometimes it does and sometimes it doesn't. I would recommend that you go start with a small amount and just see how you do. I mean, yogurt should not irritate the bladder unless you already have a biome issue. If you people who flare to yogurt are having a histamine reaction. There's a small group of patients who cannot do yogurt. Most patients can do yogurt, especially like a Greek yogurt, a thick yogurt. As long as it's not lemon, I mean, just pick an ice. I right now am doing I do a fat-free unflavored yogurt, and I like it. I just use a little bit of blackberry jam, and I like it. Lori says, spinner is a super fun game, and you and your neighbor might play it. I know. I was telling him last night because he hadn't played board games in years. I mean, he literally brought over the games he played with his kids, and I had my brother gave me Cat Monopoly like 5 years ago, and I had never opened it because I had nobody to play it with. Because I was caring for my elderly parents. I wasn't hanging out with my sister and my brother and the nephews. And so we finally broke out Cat Monopoly 2 weeks ago. Oh my God. I have never laughed so hard in my life. It is just, then we did a train game the next time we did it. Last night we did life, and Cat Monopoly was hysterically funny. It's okay to play. Don't let your age or other people's influences stop you from doing things that are fun. So I will check out Spinner. I will check it out. But anyway, I was telling him about Cards Against Humanity. Cards Against Humanity. It's like it's a deck of cards with every single thing you're not supposed to talk about in polite company. From politics to sex to cursing to all sorts of things. And anyway, playing Cards Against Humanity is absolutely hysterical. But as long as people understand that it can be a little naughty and politically incorrect. But it's all about the laughter. I'm very proud that I won my first Cards Against Humanity tournament against 40 other people. And on one case, the thing is nobody, the person who is the controller for each round, they don't know who said what, and so then people pick. They have to pick the one they like the most, and which means they either pick the one that provokes the strongest reaction or the one that makes them laugh the loudest. And a couple of times I won, and they're like, I raised my hand, and they're like, "You! How can you be that way?" And it's like, you know what? We all have a naughty side. Kayleen says, I stand by these bladder Botox. I see my urologist in January, so we're thinking in March might be the next one. Okay. Well, that's a good way away. But I need to see a hematologist because the labs are off and you have easy bruising. It's still here. It's so frustrating. And Kayleen said Kayleen and I and Kat, her friend, we played Cards Against Humanity several times. It was fun. I just needed to, Kayleen, I was in crisis trying to respond to the trauma of my surgery. And it hurts so much to be on the computer. I mean, physical pain combined with just the stress of life and frustration and all that sort of stuff. I just had to stop. I just broke. And then I went into deep therapy, and then I did EMDR, and I'm much, much better now. I did EMDR in January and February just to deal with the trauma. But the other thing that I'm really feeling right now is that I only want to game like one day a week, which is usually Saturday. And I want to create multiple income streams. And so I'm working on a lot of projects right now because I refuse to be 65 and retired. I have got a lot I want to do, and I want to feel financial security. And so I am writing books. I'm creating a new website called The Happiness Corner, where I'm going to be doing some social media stuff, and with AI, I want to do more that's fun. I just do. So I haven't played Fortnite in months. I did log in yesterday for the live event, and it was ridiculous. And I was in a game. We were down to 2 people, and the event started. And then the guy left, and I was the only person in my game watching the rocket launch, which lasted 5 minutes. And then I won my game, and then I logged off, and I put the computer back on the shelf. Life. All right, so I am here as long as you have questions for me. So give me some questions. Is there anything you want me to talk about? Let me know. And you know what? Enough about me. How are you doing, guys? How are you doing? How are you feeling today? How was your week? How was your week? How's your IC? Is it stable? Is it getting worse? Is it getting better? For me, my pelvic floor is not happy with me at all. I have not been doing my internal work. Oh, wow. Oh, I thought it was an eagle. My pelvic floor is quite angry with me right now. I can feel it right now. I have a pulling sensation. I need to go do my wand work. I've not been using my estrogen as regularly as I should be, so I'm starting to get that urethral feeling, that where you feel like you have a drop of urine stuck in your urethra that won't come out. Yeah, I'm there right now today too. Because I can be passive aggressive with my care just like we all can be. Hey John, how you doing, dude? Your doctor recommended cyclosporin. I'm not sure what to think about that. I think it might be a really good idea, honey. It would be a fascinating, it doesn't mean you got to be on it for the rest of your life. Sorry, my glasses are crooked. But for some patients, especially patients who are not responding to therapy, cyclosporin has been a complete game changer. It really might not be a bad idea to give that a try for a month or two to see what that does. It's the only challenge with cyclosporin is that it does come with some pretty hefty side effects. The one that's the most concerning is just blood pressure. So I have a friend who had very, very severe IC and had done everything, and the doctor finally put her on cyclosporin, and it was a total game changer to her. Pain dropped dramatically. She didn't need to use her pain medicine, and that helps us understand at least some of the mechanisms of action behind why she struggled with persistent pain for so long. And you also have been a persistent pain patient, so I think the cyclosporin is would be something I would really seriously consider. I would. All right, time for a pee break. Everybody, let's go pee. And then you got to rate your urination on a scale of 1 to 10 as to how easy it was to start your urine stream. So I need to pee, so I'll be right back. All right, I give myself a 5. It was long and slow. There was volume there. I wouldn't exactly call it a full heavy flow. I would call it a moderate flow. John, I don't know what happened to your post. It was there and then it's not there. Kayleen said, the peak out is driving me crazy, which is why I chose an SUV for a rental while my car is in the shop. I'm seeing, girl, why is your car in the shop? What happened? I'm seeing my OBGYN specialist on August 13. My physical therapy is going to start me on the wand this week, for which I'm so nervous for. Any insertion is excruciating. Yeah, you got to work on it. You just got to practice, honey. You know, as long as the wand is really lubed with KY, it should be very easy to slide in and out. Especially if you get the glass wand. Let me go here. New computers are so difficult to set up. here, hold on a sec. I gotta deal with this YouTube situation. All right. Kayleen said, I got into a slight car accident last month. The guy at fault paid for everything out of pocket. He's been in the shop for a week, but coming home tomorrow. Excellent. Judy said, do you know if they still make the pre-leaf individual packets? I can't find them anywhere. Let me look. Hold on. Let me see. Yeah, they're still making it. I know I don't have it in the, I don't have the packets in the ICN shop, but I do have, hold on. I do have demo boxes. I don't know what the expiration date is. Let's look at this. Hold on. Reading glasses. How do I read this? Wow, this is so hard to read. Oh. This expires in 2030. Is that what it says on the box? Well, anyway, honey, I have some. Why don't you email and we can make a deal? Yeah, they should be on Amazon. They should be on Amazon too. Kayleen said, oh, sorry, she had a 2024 Nissan Rogue and it was a lot easier on PGAD. Yeah, that's what I drive. Yep. Makes sense. Let me just take a look here. Do I have anything new that's come in this weekend? So hold on. So I'm working, oh God, we're doing so many things. We're just almost finished with our IC 101 Guide to Managing IC Flares, which is about double the size of the one in our magazine. Then we're doing our summer magazine. Then we're doing our Guide to Managing the IC Diet. Then we're doing our IC 101 Guide to Managing Pain. Oh, holy moly. Wow. Whoa, is this timely? Wow. Hold on. Rapid progression of maculopathy after pentosan polysulfate cessation. Damn. Okay. You know what? Hold on. I want to share my screen. And guys, just so you know, this desktop is really messy. Oh, okay. Here, hold on. Can I share my screen? because I'm not using my streaming software right now. Can I? Hold on. I thought I could share my stream. No. Okay, I cannot share my screen, but that's okay. So here we have, this is published July 18th. Okay, 9 days ago. This is a case study. A 75-year-old woman presented with a history of intermediate age-related macular degeneration and progressive blurring of her central vision beginning at the age of 69. Fundoscopic examination, which is of the retina, revealed retinal pigment epithelium abnormalities and multifocal outer retinal loss. The patient had first been prescribed Pentosan at the age of 63 with a cumulative dose of 1,300 grams over time. She stopped it at the age of 71. She's now 75. She was noted to only have minimal retinal changes prior to stopping the drug. 4 years after stopping the drug, the patient reported marked night vision and color vision abnormalities and was noted to have severe retinal changes, including macular atrophy. Conclusion. Pentosan polysulfate maculopathy, and remember, pentosan polysulfate is a generic name for Elmiron, is an acquired toxic disease that can significantly impact a patient's quality of life. Our report highlights that marked progression of retinopathy can occur after drug cessation and that patients need to be carefully monitored and given supportive management. Heartbreaking. Heartbreaking. Can you guys can hear me now, right? All right, hold on a sec. Judah says, I started with a low-grade Klebsiella infection in June of 2019. You took a retest on June 19th of this year. You took a retest on July 14th. It was clear you had UTI symptoms on July 23rd, and now it's back, low-grade Klebsiella. To top it off, I developed a yeast infection. I'm not doing well at this point. Waiting for a doctor to prescribe another antibiotic. I'm sorry, honey. Hold on a sec. What did I do here? What did I do? Sorry, guys. Facebook is being weird. See, it's like I've lost your comments, so hold on. Okay, now I've got your comments back. So Judith, it appears that you have maybe a drug-resistant Klebsiella infection. The fact that the first medication didn't kill it completely. I mean, it took over a month to come back. So I would be asking a couple of questions if I were in your shoes. Number one, I would want good antibiotic sensitivity testing or next generation DNA urine testing to to make sure that this is not a superbug, a super drug resistant infection. But the other question I think worth asking is, what is the quality and health of your skin? if you are in estrogen atrophy, you've lost that nice protective coating. And so basically bacteria can just swim up to your bladder wall and infect the cells. So we want to get your skin as healthy as we can. And we would do that potentially with estrogen. But then the other question that I think is worth asking is if you have 2 infections in 6 months or 3 infections in a year, that puts you in the complex UTI category or the recurring UTI category. And in that situation, we always want to try to understand, why are you getting infection in the first place? What is it about your body that's making you vulnerable to infection? And again, estrogen atrophy would be the very first thing we'd look for. But the second thing that they would look for would be the health of your immune system. Because sometimes our immune system struggles and makes us a little bit more vulnerable to infection. There is a condition called CVID. It's not COVID. CVID is a common variable immune dysfunction, something like that. And it's an age-related immune issue, or it can also happen from toxic exposures where the immune system begins to struggle. And I have a family member who has this and had bladder infections for years and sinus infections for years. And when they actually measured her immunoglobulin G level, she had none. Her body was not making, her immune system was basically shut down. And that's why she was struggling with so many infections. So now she gets infusions of IgG and her body is doing much better. So sometimes that's an age-related issue, and sometimes that's, just something else that might be going on with your immune system. Lisa said you didn't hear the first part of the eye issue. So this is a patient who diagnosed with IC in her 60s, probably an estrogen atrophy patient, given Elmeron at the age of 63. She stopped the Elmeron at the age of 71. When she stopped it, her eye damage was minimal, but now she is 74 or 75, and her eye damage has become very severe, and now she has atrophy in her retina, which means that her retina is basically being destroyed. It is breaking down. And this is a published case study showing that after you stop the medication, the eye damage can persist. Now, this isn't the first time. We have 3 studies now that have shown that. Some are larger studies that have shown that retinal disease can progress well after you stop the medication. And the first doctor who brought this to our attention, this was really interesting. This was an eye doctor at Harvard University. And she had a woman come in who had problems with one eye. The classic symptom is your eyes can't adjust from light to dark and dark to light. And you might have blind spots, you might have wavy lines. It's a very clear vision issue. So this woman came in with this really, significant issue with her eye. And this ophthalmologist at Harvard just couldn't figure it out. I mean, they ruled out genetics. And she ended up saying, I think that this is a toxic exposure, that something has damaged your eye. So that woman goes on her way, and she comes back years later, 7 years later. Now it's in the other eye. And the ophthalmologist at Kaiser does exactly the same thing. Same workup, looking for anything that would explain this, and came up with the exact same conclusion. This is also a toxic exposure that has damaged your retina. And then months later, I think it was months later, the first research about Elmeron causing the eye issues came out in the Journal of Ophthalmology. And she saw that, and then she thought of this patient and went back into her patient records and realized that this patient had been taking Elmeron for an extended period of time, and in fact was probably one of the first cases diagnosed at Harvard of this pigmentary maculopathy caused by Elmeron. But what makes her story all the more compelling is she stopped the medication at the first visit, and yet 7 years later it was in the other eye and progressing. And that's what the researchers at Emory were very concerned about when they first tried to bring this to the attention of urologists, is that they were very concerned that it would lead to progressive eye damage even after the medication had been stopped, and that has now been found to be true. All right, guys. Well, listen, I think we're at the natural end of this meeting. I think you're done. And so I think that, what am I going to do? I'm probably going to go walk around the lake, and then I'm going to come home and paint something. So, all right, guys, I'm going to call it here. But, John, I'm here for you. If you want to call me, call me. I got my phone right here, okay? All right, you guys, I'll see you later. Have a good day. I'll see you next Sunday. And maybe even Friday. All right. You're welcome, Lisa.